That's fine. That's fine, Jim. So, thank you so much, Jim, for a brilliant presentation there. And as he said, we're going straight over to Mandy now, who's going to do mainstreaming. Over to you, Mandy. Thank you.
Thank you, everyone. So my name is Mandy Derbyshire. I'm the Regional Lynch Syndrome CNS and Educator for the North West. Next slide, please, Rainers. I'm just going to talk to you today about the Regional Lynch Syndrome nurses, their role, any sort of online training that you can do independently yourself, and obviously the dreaded word mainstreaming and what that involves, and hopefully put your mind at rest as to what mainstreaming means and what it entails. Next slide, please. So I work with a big team of regional Lynch syndrome CNSs, and I know one of them's on this meeting as well, which is nice to see. But there's lots of us. So if you are from different areas within the country joining us today, please have a look at sort of who's in your region and take their email down. If not, please be in contact with me and I can point you in the right direction. So as you can see, just go back a minute, Rainus. Sorry. So there is a big team, and we all are helping to train the mainstream sessions together. But there's also the Northwest GMSA who are helping drive this project forward. And their aim is to enable professionals to provide effective diagnosis and treatment to patients, personalise their care using genomics and genetic testing and embedding that genomics into routine healthcare. So genomics is here and it's present now. It's not in the future anymore. So we need to try and get on board with it. Next slide, please. Like I said, we're here to try and raise awareness for Lynch syndrome. We're here to support the CNSs that uptake that mainstream training. We're here to signpost you to relevant patient information. There's plenty out there. We don't need one for every trust. And it helps create uniformity and standardization with patient care as well. If we're all doing the same thing and providing the same information, it's an equity of service. So we'll support you in providing that information to patients and help you through that mainstream training so that you feel confident and competent in having those conversations. We can't ask you to practice something that you don't understand and you haven't practiced yourself. So we're here for that as well. And provide you with that continued support to link nurses and Lynch syndrome champions within your trust, oncology nurses, and develop that new knowledge and skills based around Lynch syndrome. Next slide, please, Raina. So we all know Lynch syndrome is a genetic alteration, causes a predisposition to cancer. And we know that for every one person we diagnose with Lynch syndrome, there's on average an additional 3 members that we can diagnose and put them through that programme to hopefully achieve what the NHS England long-term plan is by sort of finding 75% of cancers at an early stage. So if we're screening these people, we can try and achieve that. And it's estimated that there's over 1,200 cases of bowel cancers a year, many that are under 50 that are caused by Lynch syndrome. And obviously that missing 95% that we're talking about, we're trying to find those so that we can help manage them, their family, and put them through a surveillance programme. Next slide, please. Now this lovely pathway, I won't go through it, but I'm sure all of you have seen it multiple times. Now I'm one of these very sad practitioners that have this laminated. So when I do my MDTs, I do have this in front of me because although I know that the pathway, it's a good visual aid, and it will help you through that when you're discussing patients. And it's not a bad thing to have this type of thing with you to go through, and it's just a sort of remind you that this is what you need to do and this is the pathway you need to follow. Next slide, please. So to start with the training, we always recommend these 2 options of training which you can do independently. So option 1 is all about the pathway. They're split into colorectal and endometrial, and they take sort of 5 to 10 minutes for each one to do. And then if you are keen to go on to do the mainstream training, there's another sort of 6 modules that you can have a look at. They're not particularly long, so you can do them at your leisure and go through it. So we'd recommend everybody who is part of the MDT does option 1, so that everybody understands that pathway specific to your tumour site. But also, if you do want to go on to the mainstream training, whether you're an ACP, a CNS, or a consultant, then we would recommend first step is to go through this option 2 mainstream training, which is all online. And if the links are at the bottom, but if you do need any further information, please don't hesitate to contact any one of us. Next slide, please. So on the RM Partners website, as you can see, there's resources for patients, and there's resources for professionals as well. So everything's on this website, links to different supporting documents as well, and obviously the pathways are all on there for you to download. Next slide, please, Raina. Now, the RM Partners have created a new set of leaflets for patients. So this is the endometrial one, but they also do a colorectal one. And there's lots of information in these. So if you go to the next slide, please. It shows you what it means by having an inherited cancer or a gene, mismatch repair genes, and talks about the 4 genes that we're looking at, and also mentions about EPCAM as well. So what Lynch syndrome is, what's the testing, and also, if you go on to the next slide, this is a little my test results. So you can actually put on what gene is affected, and they can take this away as a little card, and they know what is going on. So do I need a clinical genetics appointment? When has that referral been made? And also, like Jim previously said, the gene has an effect on what surveillance you and your family would be put under. So actually it can give them more detailed answer of where they can find the information specific to them. Next slide, please. So this is just to try and break down the diagnostic pathway, making it a bit easier. So we should be automatic in our response for testing those with colorectal or endometrial cancer. Sometimes this happens on the biopsy, sometimes it's on the post-op histology. It just depends on whether you can get a confirmed adenocarcinoma or a cancer on that biopsy. And this will obviously take place in accordance to your SOP or your trust agreement, whether it's IHC or MSI. And then that will tell us whether we need to offer that patient genetic testing or germline testing. And now, ordinarily, all of these patients used to go to clinical genetics team. And those that aren't mainstreaming, that's the continued practice at the moment. But the idea is that if you are mainstreaming and we teach you how to mainstream, then that genetic test actually takes place locally in your trust. So it can be done for that patient locally. And this can be done by the CNSs or any consultants that are trained or wish to be trained in mainstreaming. And this is to help target their treatment. So targeted therapies such as immunotherapy versus chemotherapy, or also surgery. So whether you have a total colectomy or segmented colectomies, depending on that gene that's been identified. And then put them into that surveillance program. Know what they need, what we need to do in terms of how many sort of scopes they need to do, from what age, what implications it has for the family, and further treatment options for them. Next slide, please. Now, Kevin Onahan touched on this slide earlier, and sort of showed the effects that the MMR was taking about 24 days to come back. And then further testing, sort of such as your BRAF or your methylation testing, was having a further 56 days. And then when those that needed genetic referral were getting there and actually getting that diagnosis. It was on average 286 days. Now that's coming up to a year. And our clinical genetics service is under a lot of pressure and a lot of strain at the moment. So sitting there for a patient, sitting there waiting for that diagnosis, and waiting and sort of having that pressure on them, is quite a big undertaking. So on the right hand side, this is our aim, this is our sort of what we're hoping for. So with tests being done either in-house or at local hubs, we're hoping that that IHC or MSI does come back within 7 to 10 days of that biopsy or post-op histology that's taking place. And then the relevant BRAF or hypermethylation does take place following that. And we would like to achieve a 62-day target, which we all know about when it comes to cancer targets. But this is to try and get somebody either referred to clinical genetics or actually undertake that germline testing in-house. So if you have a look at the left-hand side, you might be taking 12 months to get somebody to that germline testing point, and we're hoping to cut that down to 62 days, which is a massive difference. And to be able to provide that to a patient locally is unbelievable. The amount of patients that I look after that go, oh, I don't want to go all the way to that hospital, can you not do it here for me? You know, having things locally is a massive thing for patients, not having to travel and having their chemotherapy and their treatment at home in their home locality is really important to patients. And that's been highlighted on the cancer surveys, the patient surveys that have come through as well. Next slide, please. So how are we going to achieve this? Next slide. Mainstreaming, the word everybody loves. So mainstreaming, it refers to the shift of genomic testing away from clinical genetics to other clinics and specialities. Within Lynch syndrome testing pathway, this means healthcare professionals and cancer MDTs becoming directly involved in consenting these patients for germline testing and communicating those results. Next slide. So why are we mainstreaming? What's the benefit? Why are we doing it? Like I said before, to reduce that waiting time for the genetics service. I know that some of my patients before we were mainstreaming were taking 6 to 12 months to even see the clinical geneticist, which is a really lengthy amount of time when I could potentially see them within weeks of that cancer diagnosis. Providing an equity of access, so patients being able to come to their local hospital and we providing them with that service. Rather than them potentially travelling a distance to get to the genetics team. I know a lot of my patients, they don't like things that are unfamiliar. They like being closer to home. They know the services at home. They know the team at home. And it's that relationship they have with their oncology or surgical team. And actually having that service at home with their team benefits them and that relationship between the team. Hopefully getting that earlier diagnosis, so bringing that waiting time and that diagnosis down from sort of 300 days to 62 and getting that test done. Colorectal and endometrial clinics. Now, all patients in both colorectal and endometrial clinics should be able to offer this service to patients. But I know that I've had some gynae CNSs that are worried about the competence of providing that service because they're not having the numbers like colorectal team might be having. So actually in my area and my trust in Langston South Cumbria, we're coming to an agreement where actually the endometrial and colorectal patients that need germline testing are actually being done under one CNS. So I'm providing the service for colorectal and endometrial patients with my trust because I'm doing it more often and actually feel confident and competent at seeing those patients. So that's also an option. It's not everybody within every trust has to have one endometrial and one colorectal CNS or consultant doing it. There are other options of providing that service locally but providing that reassurance to the clinicians as well. So, like I said, as the endometrial numbers were low in our area, that was the decision. But it's down to the confidence and the clinician's scope of practice, and how happy they are in providing that service within that locality, and actually working together as a clinical team and going, actually, you can provide that service for me, and therefore I will refer to you. So working as your own MDT for this cohort of patients. Next slide, please. So what does the mainstreaming training entail? So obviously I've talked about the RM partners options, option 1 and option 2, and that's what we'd recommend before anybody went on to do the further mainstream training. So this gives you a core basis of knowledge. And then the mainstreaming workshops that I provide for the Northwest, they provide you an opportunity to practice this consultation and to go through different variations of consultation, but the context is the same. So the patient is getting the same information across the Northwest, but some people use different wording, and for your locality, you've got to tailor that consultation to your patients as well. We talk about ethics and confidentiality surrounding that consent as well, and provide you with competencies to be able to achieve and feel confident in what you're practicing. And we talk through different consultation techniques and clinical scenarios as well, because not every consultation will be the same. And obviously drawing that family pedigree and going through family history taking as well. Some people are quite confident at doing that, and others, this is a brand new skill to learn. So we'll go through that as well. And then at the end of the workshops, we talk about the practicalities of setting up this service, and go through clinics and how you want to sort of set up the service for the area. And like I said, within Langston South Cumbria, we decided to set it up in a particular way where colorectal CNSs were going to see the endometrials as well as the colorectals. But obviously Manchester's different. There's gynae CNSs and colorectal CNSs on the mainstream training. And it depends on how your service works and how you want to provide that service. And also try and get the links to the genetic counsellors and the genetic consultants, provide you with that link so that you've got the support and know somebody's there to provide you with that further information if you need it. And they can also provide you with that clinical exposure to patient conversations as well, and provide you with that practice and new skills and knowledge. Next slide, please. So what is part of the genetic conversation? What is involved in it? So providing patients with that information, so information about Lynch syndrome, whether it's from colorectal cancer or endometrial cancer, there's lots of information leaflets that you can tailor it to. Obviously taking a family history and drawing the family pedigree, which I find personally extremely helpful, because it can show you trends for patients' history and cancers within that family. Helping you understand those 3 possible results. Unfortunately, they're not black and white. It's not positive or negative. We do have a grey area in between. So it's learning those 3 different results and actually conveying to the patient that there are 3 different results. It's not a yes, you have Lynch syndrome, or no, you don't. And it's providing all that information to patients and understanding the implications of those results and explaining that to them. And then there's some possible surveillance options for them as well. Next slide. So this again goes through the genetic conversation pathway. So for me, as you can see in the middle, it says send information sheet to patient along with family history questionnaire. Now I found this extremely helpful. So before patients come to see me, I send out a family history questionnaire and a Lynch syndrome information leaflet. And when those patients come to clinic, I make sure that they've had that information and they bring that family history questionnaire with them. Because more often than not, If they're a man, unless they've brought their wife, they don't know any dates of anything. Sorry if there's any males on there that's been offended, but that's usually the case in my clinics. As long as their wife's there, they know everything. So actually this helps a lot so that you can get a full and an accurate family history from that patient. We obviously discussed the testing and the 3 possible results, and we have a pathology unit, so I usually send them round to get their bloods done there and then. When the results come back, I'll put them through my MDT, and if I'm unsure, then I will link into the expert team, such as Professor Jim Hill or Dr. Fiona Lalu, and ask for their opinion or for help. And obviously, if they are confirmed Lynch syndrome, I will send them across to the clinical genetics team, where they'll have an appointment and go through sort of cascade testing for family. Next slide, please. So within the Northwest, we've developed a hopefully simple results pathway for everybody who is doing mainstream testing. As you can see, your positives get referred to the clinical genetics. Your negatives, we can reassure the patients. And like I said, the grey bit in the middle, the VUS, the variant of uncertain significance, there's a pathway there for you to follow. And like I said, when you go through your mainstream training, we will set you up with connections to those experts on the MDT to help you make those decisions about those patients. We're not expecting you to do everything. We are still here in the background to support you and to give you that confidence and reassurance of what you're telling a patient. Obviously, despite any of these results, this is the criteria for referring to clinical genetics. So if any of these apply to your patients, then we would still recommend you send through to the clinical genetics team. Next slide, please. So your support network, like I said, we're not expecting you to do any of this on your own. We've got a wealth of knowledge and experience within the team, and everybody is more than happy to help. We might not work in your trust, but we are here and we're available for support or questions. I've even been asked to come and sit in on somebody's first genetic germline conversation to provide them with that support, and that's what we're here for. And like I said, we provide you with the links to the genetics teams where patients are going to be referred into if they're positive. And the regional expert centres and specialist MDTs to offer you that advice and support in the cases where you're just not sure or you want further information or support, so that you can then provide that reassurance to that patient. We've also, I know teams and myself who've set up the clinics locally. You don't reinvent the wheel. We've been there before. We've probably been through the questions and the pitfalls of setting up new clinics and services before. So please ask for any advice and we can help. We can provide ongoing education and training. And like I said, with the clinical genetics team, they have been amazing and very accommodating to the CNSs who have been through the mainstream training and are welcoming them to their clinic to get that exposure to those genetic conversations they're having with the patients. And hopefully we are looking at trying to set up the community of practice. And Beatrice, you were asking questions about that, where you want that network of other mainstreaming doctors and nurses to bounce information off and scenarios, and we will be supporting you through that. And once that's all set up, obviously everybody will know, and we're more than welcome to provide all that information. Next slide, please. So I put a few extra educational resources in for those who want a little bit more information. So it's not just around Lynch syndrome, it's around genetics and genomics as well, and DNA. So these are sort of quite quick little ones, 2-minute videos or 5-minute videos, and here are the QR codes that will take you straight to those websites. And they are a wealth of knowledge, videos, patient information, leaflets. So it's very worthwhile logging on to those. Next one. And then these are a little bit longer, so you've got your 10, they take about 10 minutes or 30 minutes each, but especially Genomics 101, I can't recommend it more highly. It is fantastic. It goes right from your basic DNA, where it all started, and then takes you all the way through as to why we're doing this testing, and the steps as to why we're wanting mainstreaming for these patients. Next one. And for those of you who want even more experience and knowledge, there is a Bristol UWE course. I think the next cohort now will be the January or September next year, but there is a link there for when that becomes available and you can apply for that course. And JEP, or Genomics Education Programme, they've got an amazing resource on their website as well, with lots of information and videos to help. Sometimes actually doing the same thing in lots of different ways sinks in a bit better than going through the same type of education programme. So there's lots there, and anything else, if there's any more information you want, please don't hesitate to ask. Thank you.
Absolutely brilliant, Mandy. And you know, it just strikes me how important the role of the nurse really is. I mean, all the professionals are very important, aren't they? But this really is something that nurses can be coached, encouraged, you know, then, and they're not on their own, are they? Which I think is the message that I'm taking home from your talk.
Definitely not. There's plenty of people out there. I mean, I don't pretend I know everything, and I have people that I can lean on and support. It's a massive team with a fountain of knowledge. And if I don't know the answer, then I am pretty sure I can find somebody who does. And it's that networking, it's those sort of step ladder of people that you can go to, a cascade. But we are all here and we're all more than willing to support. We've probably been through it before as well. So, you know, that type of thing is always helpful.
So if somebody felt a bit nervous about embarking on kind of even just starting at the beginning of, like, if they felt that they didn't know enough about genomics, is that the kind of thing that you can help signpost and support?
Definitely. I think when I first started, it was, or it was first coming through, I was a little bit apprehensive. I understood it and I thought it was amazing, and yes, I really got the drive and the need for this, but I didn't have that background or that foundation knowledge and wanted to find out more. So there is lots out there that I can point people in the direction of, and starting at the bottom, working your way up is a lot scarier than coming in from the side. So yeah, we've all been there. I've definitely been there when I sort of started on my genomics journey, and it's definitely worth sort of leaning on your peers or asking questions. Asking questions isn't a sign of weakness. It's actually, I think it's an extremely good quality to have, because it means you want to learn and you want to get it right. But there's lots of us here to help.
Brilliant. Brilliant. And just, it's those insights that just, you can't ever underestimate how important it is to hear a fellow nurse say, you know, I started at the beginning, and you know, and this is where I've got to, because you know, we've all got to start somewhere. I mean, I did the 101 and I had to play one of them about 9 times because I just couldn't get it into my head. But you know, there's such a wealth of resources, isn't there, which is brilliant. So thank you so much. Are we ready to go to our next speaker? I think we're a little bit early for the MDT discussion. So, Mandy,
Just,
if you... Oh, hi,
sorry.
Jim, you're back.
Yeah, I'm just checking who we've got. We've got
Michael.
We've got Mike here. We've
Yeah.
got Fiona here. we've got Katie Newton here. We did have Dina. I'm just checking if Dina is still here. I just think she's still on the. She was here earlier.
I'm here, Jim.
Oh, I see.
Oh, brilliant.
Thank you. So I think we're okay
We're good to go.
to start.
Brilliant. Over to you, Jim.
Okay. So if we could have the first slide up then, please. So this is a 43-year-old male. And we're talking quite a few years ago now when the patient originally presented, so 6 years ago. Emergency presentation with obstructing splenic flexure cancer. I know Dina's been having a look at these slides. Have you had an opportunity to see this one, or do you want to just comment on the image in front of you, Dina?
Yeah, I've got the case set up actually on my Sectra, and I can share my images if that is more useful, but I don't know if I have control of the, if I share, will it work?
I think it will. It's just important that we then take it back. I think that was the...
Okay, so let me give that a go then. So share screen. And just let me know when you can see my my screen.
Yep. That's great.
Perfect, perfect. So this is the first set of scans from 2017, and you can appreciate that he presented with a really bulky splenic flexure tumour. So as I scan through, you can get the feel of how bulky the tumour is. It extends from splenic flexure all the way down to mid-descending colon. Very locally advanced, lots of tumour going beyond the wall of the colon. And at this point as well, there was evidence of localised perforation. This area here is a collection just anterior to the colon containing gas and fluid, showing that he had perforated. Tumours in contact with the spleen and at the back of the pancreas. So very locally advanced. And at this point, you can see that his liver is clear, no metastatic disease.
Okay, that's lovely. And then we will take control back. I think if Rainis will do that. If it works first time, we should be okay, Dina. Carrying on with this.
Oh, great.
So I think, I don't know whether Fran McNichol is on as well as Katie. So I'll just come to Katie. So not a very nice looking scan, Katie. Better done middle of the night or during the day?
Definitely middle of the day. You'd want to have some colleagues around, I think. This is going to be a fairly meaty resection. But yeah, a subtotal colectomy, and obviously concern about the attachments to the spleen and the tail of the pancreas. I'm not quite sure whether there was any on-block resection done at the time of those organs, but obviously you'd want to have plenty of phone a friends around in case they were needed.
Yeah, absolutely. And it's a localized collection, so I agree it will wait till the following day.
He wasn't peritonitic with that localized collection.
Obviously, this is a historic case, but we are going to be having splenic flexure cancers where we've got an initial immunohistochemistry, which might show loss of one of the mismatch repair proteins. Do you think it's reasonable to use that evidence to, without knowing if there's a germline mutation, to determine whether the patient has a segmental or a subtotal colectomy? That's going to be quite a common scenario, I think, in the months and years to come.
Yeah, absolutely. Obviously, you've got to take into account the patient's age and sort of think about functional outcomes. But I think in somebody in their early 40s, like this gentleman, if he'd had demonstrable mismatch repair deficiency on his upfront immunohistochemistry, then doing an extended resection is absolutely reasonable. If it was MLH1 or MSH2, obviously the jury's out with MSH6, but I think even with the younger patients, you'd err on the side of doing an extended resection, and either doing iliodistal sigmoid or iliorectal, depending on your preference.
Okay, could we have the next slide then, please, Rainis? So I think, Mike, and thank you very much for putting these cases together. So I think you looked after this guy at that time, is that correct?
Yeah, that's correct, yeah.
And clearly some concerning features on the scan. and possibly the histology, and you at that point this would be a fairly standard regimen at that time.
Yeah, so this is sort of standard adjuvant chemotherapy regimen. I guess it from a very specific oncology standpoint, that a stage 2 patient with MMR deficiency, there is some uncertainties about stage 2 cancer. We'd often give single agent treatment, but there's uncertainty about the amount of benefit those patients get from the capecitabine on its own. So if somebody's fit, there's the option for combination treatment that may work slightly more effectively. And given his age and his pre-morbidly very fit, that was the sort of oncological kind of decision after discussion with him to go for that sort of more aggressive treatment. And then obviously with this case, because he was an acute presentation and he hadn't had the sort of biopsies done pre-op, but as you said, he then went on and had MMR done post-operatively, and he'd got MSH2 loss and some family history, not of colorectal cancer, but his father and his father's brother had both had prostate cancer in their 50s, and I think one of them had died of prostate cancer.
Okay, and just come over to Mandy, because particularly with emergency cases, Mandy, we don't. It's harder. We often don't take a family history from these patients. Certainly, perhaps might ask them about colorectal, but wouldn't necessarily always ask them about endometrial and other cancers, which is really important, and equally making sure that the reflex testing is done. How do you think we ensure, Mandy, that we get that information in all our patients?
Yeah, so I think we were talking about whose responsibility is it to do a family history, and from a CNS point of view, I found that sort of actually the CNSs are in a great position to obtain that information, and sometimes, especially after emergencies, we used to see them on the ward, and we had more time than the consultants to spend with that patient after their surgery or in clinic, to sit down and actually talk to them about them, and not just what's happened to them, and you build that rapport with that patient, and sometimes I find that actually they're more open and disclose things like, oh, actually, yes, my family member had cancer, and we do have a few bits of cancer within the family, and they might not see it as related because it's not colorectal cancer, but it may have bearings on it. So being able to get that information from that patient, I think is vital. And sometimes some people are more confident than others at pulling that information out from patients. But like I said, it is something we do on the mainstream training. So it is something that we can help build confidence in CNSs that want to do it. But I think once the diagnosis and treatment plan has been discussed with the patient, I used to stay with that patient in clinic or with the relative and go through it all and let them digest that information. And actually, you'd find that people were a bit more forthcoming with information sometimes when the doctor's gone, because they feel like sometimes they have to listen to the doctor, whereas the nurse was there for questions. That was always sort of the way people were seen in our clinic space. So I think it does help when you've got that relationship.
Sure, and there are multiple opportunities for us to potentially get that information as well, aren't there? And Fiona, so is prostate cancer, that history, significant, and what other cancers should we be asking about?
So prostate cancer is associated, certainly with MSH2, and certainly you should be thinking about other queries. Clearly endometrial should be asked about, but also if people have got any urothelial, in particular ureteric, or they'll say they've had a kidney cancer, it's worth checking on that to see if it's associated. And then there's some very obscure stuff, so you can get some skin lesions associated with MSH2 mutations in the so-called Muir-Torre syndrome. So it is just worth noting everything. Some of it may be relevant, some of it won't be. Breast cancer was thought to be associated, but I think the data now is that it isn't. So I think that is probably one thing you can ignore.
And just Emma, coming to you. So if this patient had presented electively and had been known to, and clearly been a woman, and been known to have Lynch, at 43, should we be getting an opinion from your department about risk-reducing surgery?
Yeah, absolutely. So we recommend it for people who've completed their families after the age of 40, and that usually takes the form of removing uterus as well as fallopian tubes and ovaries, because there is also a risk of ovarian cancer.
Very clear, very straightforward. And I think that's something when we've talked to the MDTs, we've tried to emphasize, Emma, a communication between colorectal and gynecological about the potential benefits of that risk-reducing surgery. Could I have the next slide, please, Rhaenys? And again, if Dina, you would wish to comment on about this, please.
Yep. Can you see my slide?
Yes, lovely.
Okay, perfect. So this is a CT scan, same patient done 6 months later. So we're on May 2018. And unfortunately, we can see that he's developed multiple liver metastases, pretty much distributed throughout all liver segments. So in the remit of being unresectable, really. Not particularly bulky disease, but just, conspicuous by number. This is post colonic surgery, so you can see the tumour's been resected and we're left with some fibrotic changes in the bed of the tumour. He didn't need to have any of his spleen or pancreas resected, but we've got some adhesions overlying both organ there, suggesting that it was maybe just fibrotic adhesions to these organs, but unfortunately liver metastases. We then went on and did a PET CT, which highlights probably a little bit better. All the bright spots are metastatic disease, and you can see there's very little of the liver spared at this point. This was a few weeks later.
Thank you. You just take that back, Rhaenys. That's perfect. Well done. That's so over to you, Mike. So
Yeah.
At that stage was sort of March 19, July 18 to March 19.
Yeah, so that was progression on his adjuvant treatment. So unfortunately, he progressed straight through that treatment, which would sort of make you fear about his sort of longer term prognosis. He then went on to have some palliative chemo because, as Dean has described it, that the extent of sort of spread in the liver was beyond the scope of surgery, even if he had a response. He didn't have any mutations, so we checked for RAS and BRAF mutations. He didn't have any, so he could have some targeted treatment in combination with alternative chemo. And he did have some initial response to that. But then, as Dina will probably show, then in March 2019, so kind of 9 months or so later, he was progressing again, unfortunately.
And just before we see those images, what would you have estimated his life expectancy to be in March 2019?
So there's an option for third line chemotherapy. It's sort of stabilizes cancer in probably around about 40% of patients, but 60% will progress. And the median survival in the trial that sort of demonstrated the benefit of that drug is 7 months. So you would imagine from March 19 that he would certainly live less than a year.
Okay, that's very helpful. And next slide, please. And again, Dina, if you would be good enough to take us to March 19 and then March 2023. Just you on mute, Dina.
Sorry, I was just blabbering away to myself there. So this is his scan from October 2018, just to show you initially that he did have a degree of response within his liver on his chemotherapy. Still lots of metastatic lesions in the liver, but slightly smaller while he was on treatment. And then moving on to March 2019, unfortunately, this shows evidence of progression. So multiple liver lesions again throughout all lobes and segments, and increasing in size on treatment.
And then so I guess the intervention that we then made was that we made a compassionate use application for immunotherapy. So at that point, immunotherapy, there'd been some early studies of relatively small numbers of patients, but the drug was not approved for use on the NHS, and there weren't any trials going on. So we made a compassionate use application to a drug company, and they thankfully said yes. And so shortly after that March 19 scan, he started immunotherapy. And then, as you can see, his life has extended far beyond that sort of 7 months that might have been predicted back in March 19. So he's still going strong on treatment at the moment. So Dina, do you want to show the sort of most recent scan?
Yeah. So the scan I chose was May 20. He's had some scans obviously since then,
Yeah.
but I thought that this was a really nice example of just how remarkably the metastases have melted away. So he's still got the odd little dot in his liver, which may just indicate burnt out disease. He did also develop a tumour thrombosis within his portal vein, which is what this linear area represents, but really a remarkable response. And his liver looks the same now, I think.
I mean, it's astonishing, really, that response, isn't it, Mike? And a great credit to you for getting that drug for him. Comment on side effects whilst he's been on it a good length of time, much in the way of side effects?
Yeah, so I guess if you look at the trials, the commonest side effect that people get in terms of autoimmune problems, that tends to be the sort of key component. You know, you can get rashes and infusion reactions, but the sort of main side effects we worry about are autoimmune phenomena. The commonest is hypothyroidism, so it's fairly easy for us to monitor patients for. They have routine thyroid function every time they come, and about, as I said, 10% of patients get that, and obviously it's easy to treat as well. And then a small proportion of patients will get some sort of itis of another part of the body, so hepatitis, colitis, pneumonitis, kind of anything you can think of can get inflamed. He had some degree at one point of proctitis, and ended up sort of seeing people about whether that was a disuse proctitis or drug related, but then that seems to have sort of burnt out, and he's sort of been able to maintain on treatment without further problems. So he's in fact coped extremely well.
So obviously the treatment effects here are so dramatic, they are going to change many of the treatment strategies we've used. So if you saw a patient with Lynch and liver metastases, which was potentially resectable, it's going to be quite difficult to know whether you should use immunotherapy or surgery.
Yeah, I think we're still on the learning curve with all of this, because as Dina said, what you don't entirely know is what's left, you know, and kind of the treatment he's on is until progression or intolerance. So, you know, there's just that question at the moment of, are we treating viable disease, or has everything resolved? And there are some studies of it as neoadjuvant treatment, which we might talk about a bit later, where you do see very high rates of complete pathological responses.
I think we've got a question from the audience. How are we going to manage that, Rainis?
Jim, it's Marie. I would like to know from Mike. Mike, is this gentleman still on compassionate use?
He is, yeah. So the drug company kind of keep in touch with us, but he remains on compassionate use drug rather than having switched on to sort of NHS, because some of these drugs are now approved for NHS use, which sort of largely happened following COVID and then subsequent NICE reviews in sort of 2021. But yeah, his supply of drug is still through the drug company.
That's great. So we've got two more cases, another colorectal and then a gynecology case, Emma. So if we could have the next slide, please. So this is 2021, July 2021. We've got a 68-year-old male. He's presented with significant weight loss, recurrent infection and abdominal pain. And he's had a biopsy which shows an adenocarcinoma at his hepatic flexure. Again, Dina, if you could kindly show us some images.
Yep, can you see this scan now?
Yep, beautiful, yep.
Perfect. So this is quite similar to the previous case in that the primary tumour is really bulky and locally advanced, but this time it's on the other side. It's involving the hepatic flexure of the colon, extending over quite a length into the mid-transverse colon, and you can appreciate the extent of extramural disease, which is one of the things that we look at for prognosis. So the deeper the tumour spread beyond the wall of the bowel, the worse the prognosis generally is. There's tumour spreading along vessels, there's nodes in the mesentery, and you'll also appreciate that this structure here is the duodenum, and you can see that there's strands of tumour approaching the surface of the duodenum and distorting the surface. So very locally advanced and nasty looking at presentation. There's also some tumour up here, and this is the gastric antrum, so it's approaching the serosal surface of the stomach. So from a resectability point of view, this would be major surgery to get it out at this point, and remarkably no metastatic disease at this point.
Okay, if you could have the next slide, please. So, Katie, I think, is Fran, just check whether Fran's joined us yet or not. If she has, please comment. If not, Katie, surgery, what do you think the chances of affecting a surgical cure with that sort of CT scan?
Well, as Dina just commented, it would be major surgery to achieve an R0 resection. You'd be worried about obviously duodenum and the gastric antrum. Certainly think it'd be our MDT preference to recommend oncology up front.
Yes, there's increasing vogue for that. I think the recent trial, whose names escape me for a moment, has shown some benefit from preoperative downstaging of colonic cancer. And whilst you can't always tell about the nodal involvement, certainly are enlarged nodes there. Mike, comment on systemic therapy?
Yeah, so as you said, it's a Foxtrot study, so that has shown some benefits, particularly for T4, but sort of bulky T3, T4, and largely ignoring nodal status because of the difficulties assessing it. So for somebody with a bulky T4 tumour, considering chemo is quite reasonable, and the sort of caveat is in the Foxtrot results that MMR deficient tumours didn't seem to gain a particular benefit, and most of those tumours are in the right colon. So I think at the point this guy had been discussed, MMR was not available at that point of his original kind of discussion, but I think the MDT felt that he should probably come and have a discussion about systemic treatment. I met him, and I guess he was sort of slightly less fit than had been realised at the MDT. So he'd got a long history of diabetes, and he got established peripheral neuropathy, which impacts on my treatment options, because oxaliplatin, which the other patient had as their initial treatment and has a very high response rate, can cause peripheral neuropathy. So I immediately couldn't give that drug. So you're sort of slightly down on a treatment option. So we did at that point plan for him to have some alternative chemotherapy as initial treatment, but sent off for analysis of I think MSI and RAS and BRAF because of the chance that this might well be never resectable, and that we're looking at sort of palliative treatment. Okay,
that's very clear. Next slide, please. So this is your molecular analysis, Mike. Is MSI high? There's loss of mismatch repair protein PMS2. He's got a BRAF mutation of uncertain significance. So you've got some clues that it's there's a mismatch repair deficient tumour. And he's been referred to formal genetics. Now, so there are clues, but not definitive. How much information would you need to feel that there is enough evidence for immunotherapy? And then I'll ask Fiona about, let's suppose we really weren't sure, Fiona, and we wanted an attempt to expedite the mutation analysis. Is that ever possible? I know it's being done with some other cancer types. So I'll come to Mike, back to Mike, about how much mutational molecular evidence do you think you need nowadays to start immunotherapy?
Yeah, so essentially the licensing is that they mismatch repair deficient or MSI high, and it doesn't matter what the cause is. So that might be sporadic loss, it might be Lynch, but it doesn't matter. So him having an analysis saying he's MSI high would immediately mean that that immunotherapy becomes an option for him. In terms of colorectal cancer, there are differences in different tumor types, but in colorectal cancer, that would be sufficient. And as you said, in him, we then got his MMR done so that we could kind of let Fiona know and sort of direct potentially sort of further testing. He had no RAS mutation, and then as it says there, he had often sort of BRAF testing is done, as has probably been talked about, particularly if people have loss of MLH1, in terms of working out whether it might be a sporadic tumour. So he didn't have the common typical BRAF mutation, he had a much rarer one. So immediately that he was MSI high, we've got an option for immunotherapy, and by this point, which was approximately 12 months ago, immunotherapy with this drug pembrolizumab had been NICE approved as a palliative treatment. So with the uncertainty about whether he would ever be operable, and also with at that point some early data from preoperative trials showing very high responses, both radiologically and pathologically to immunotherapy, that seemed like the better option for him.
So you've given us a very clear description of when we're allowed to use these drugs. What about the criterion? We've obviously got license for metastatic disease. What about this indication where we're trying to downstage, in this case, colonic, but equally it could apply for an advanced rectal cancer?
Yeah, so the current licensing is as a palliative treatment, and then I guess you have a sort of blurring of what is operable, don't you? And kind of trying to work out, well, you know, the likelihood of significant response with chemo, I think we know historically is very small, and so trying to give him chemo probably isn't going to significantly impact on the situation and mean he's operable. So I think we felt at that point it was probably reasonable to kind of start immunotherapy as a palliative treatment in inverted commas and sort of see how he got on. So currently there is one sort of small UK neoadjuvant trial running, and there are 2 or 3 larger industry or academic studies planned for the next couple of years to sort of really formalise, well, what's the optimal duration, what's the optimal treatment, and the sort of pathway about when you do surgery.
Thank you. And Emma, is this situation arise with endometrial cancer? I know you said it tends to present fairly early, but does this situation occur for endometrial cancer where we might need to consider downstaging for surgical resectability?
So certainly we do have a history of doing this when necessary. It's rarely do we know that they are Lynch syndrome patients at the time, but of course we haven't been testing for Lynch syndrome in our endometrial cancer patients really until now. So this will become an increasingly, a situation that we need to be increasingly comfortable with. But certainly, yes, we do in the standard setting sometimes downstage our endometrial cancers to an operable stage using neoadjuvant chemotherapy.
Thank you. And on the basis of what Mike has said, Fiona, does that obviate the need for ever requesting any urgent mutation analysis, do you think?
Yes, I mean, I think, to be honest, the whole issue around the checkpoint inhibitors is on the basis of the somatic variants that you see, not the germline. So it's whether your tumour is deficient in mismatch repair as opposed to whether your germline is. So there's no need to do urgent testing. And in this individual, assuming it's isolated loss of PMS2 and not combined MLH1 and PMS2, you'd be looking at doing germline testing for PMS2 variants, and the BRAF mutations probably of little relevance.
Thank you. And Mandy, what counselling would you give the patient in this situation at this stage, do you think?
I think if sort of you've got your mainstreaming up and running locally, I think you're in a good position to potentially help by providing that service and providing that result. My results, I think, are taking about 8 weeks to come back from germline, but it's whether it's going to be a significant influence or help, really. I think that would be guided by the likes of the oncologist or the surgical team. But I think if you can offer that service in-house, it would be something that I would potentially ask, or is it going to help your clinical decision or your treatment plan if we can provide this service in-house and do this for the patient. But I would offer to do that for the team if they felt that it was relevant. And obviously that time scale of being able to do it in-house and getting the results back, taking pressure off the genetics service may sort of help with the treatment outcomes and the treatment pathway. So I would offer and see where there is a sort of benefit to the team and to the patient.
Sure, and I do think that having some of the conversation along what's involved in testing and implications for the family would be of help to the patient at this particular stage. Certainly, you know, to reassure them if this is a mutation, then other things can be done to help other family members. If we could just go on to the next slide, please, Rainis. Mike, over to you again, please. And do you want to talk about or wait for Dina to show the slides, Mike?
So, well, I guess it should say, so he started on immunotherapy and coped with it very well, and lots of those sort of initial symptoms that he'd had of recurrent infection and weight loss and abdominal pain all resolved. But then probably, I guess, Dina can talk us through the sort of time course of the scans.
And that's great. If you could put those up, and just whilst Dina's doing that, Mike, any suggestion that patients with mismatched defer cancers, which are Lynch and non-Lynch related, respond differently to the immunotherapy?
It's still being addressed, I guess, is the honest answer. But certainly the response in Lynch patients appears to be very good, and if anything, maybe slightly better than the non-Lynch patients. But there's questions about BRAF mutation being more common in the non-Lynch patients, and whether actually, rather than it being a better response, it's more of a sort of delayed and slower response. But we're only going to get that as we get more clinical data. So they certainly both respond, but yes, Lynch patients probably slightly better from what we could see so far.
Thank you. Thanks, Dina.
So I'm just going to show you these side by side just to give you an idea of response. So his initial staging was in July 21, and this image top middle is 4 months later in November, and it just shows the significant response to treatment in terms of downsizing of the tumour bulk. There is still residual tumour. You can see this enhancing soft tissue at the hepatic flexure. There's still tumour spread beyond the wall of the bowel. There's still evidence of extramural infiltration and vascular invasion, and you can still see contact with the stomach and nodal disease in the mesentery. So it has been significantly down bulked, but at this stage we'd probably say that staging was the same. So T4, T4N2 probably at this point, but you know, significantly reduced in size. I think the next, do you want me to go on to the next scan as well? So the next one, so we've got from November 21, next one we've got is 3 months later, February 22. I'll just make it a little bit brighter for you. So again, we can see continued response. There's still probably a small plaque of tumour some extramural disease. And at this point, it can be quite difficult to know what is fibrosis from what is active tumour. So you can still see these strands extending between the tumour and the duodenum, tethering the surface of the duodenum, tethering the surface of the stomach, but significantly reduced compared to previous. And there's no question at this point as to whether there remains active tumour. So he went on to have a PET-CT a couple of weeks later, which shows this very bright area at the tumour site, indicating that there is still some active disease, but significantly reduced from his original staging, and no metastatic disease at this point.
So looking more operable?
Yeah, I'd say so. So we're looking at adhesions now as being the problem. So there are still fibrotic adhesions to the duodenum and to the stomach as well, which you can appreciate on the PET, excuse me, as well as on the CT scan. It would still probably be a difficult resection, I think, because of these adhesions, but and ensuring that you've got a negative resection margin. We know from, with rectal cancer that staging that the surgery usually has to incorporate the areas that were involved at the original staging, because we can't radiologically say that there's no microscopic disease at the margins, but certainly there's no avid disease at the margins on the PET.
And just briefly, Mike, do we know how long we should be treating these patients for? Again, it's new territory, really.
Yeah, not really. So with this drug, the palliative trial gave 2 years of treatment. Neoadjuvant trials have used different drugs. So one trial of rectal cancer gave 6 months of treatment, and that was only presented last summer, and that showed very high rates of complete radiological response, and actually none of the patients have had surgery. And then there is a study which again was presented last autumn, so after this patient, that's looked at a much shorter period of treatment, so just 6 weeks of immunotherapy, and showed very high rates of complete pathological responses. All those patients had surgery. So at the point we were making decisions, we really didn't know, and we're still slightly working in the dark about the optimal duration. And I guess at each of those time points, he was going back through the MDT, and we were having those discussions about, well, is it good enough? How long should we try and carry on? And we got to the point after that PET scan where, as sort of Dean has discussed, we kind of felt, well, we probably now is going to be as good a time as ever.
Sure. I think Rhaenys is trying to hurry us up a bit, and I know we're running a little bit late, Rhaenys, but I think this is really valuable. So I'm going to try and get that last case in just briefly. So just go back one, if you would, Rhaenys, sorry. So Katie, again, we're going to be learning surgically, aren't we? What's, is it adherent? Is it invading? Still a difficult operation, but clearly you'd have fancied this a lot more following the
yeah, absolutely. Dina was mentioning about the difficulty with the fibrotic disease, and is it desmoplastic reaction? Is it microscopic disease? And it's a difficult call with obviously rectal cancers that have been treated neoadjuvantly. And I guess the same is true for this patient. I wasn't at his operation, but I think it was fairly clear, and the surgeons were satisfied that it was adhesions rather than disease. But yeah, like you say, it's a learning curve for everybody involved in these cases.
Sorry, Katie, if we'd done just a segmental colectomy here, Fiona, aspirin post-op, yes or no?
Depends on his comorbidities, doesn't it? Whether he can take aspirin. Ideally, you'd give people aspirin, but it depends on their age and all their other problems.
Fit enough aspirin, okay. Right, we'll just quickly do this third case if we can. And if Lucy Foster's still there, I might just ask Lucy to make a comment if that's okay. So this is a 62-year-old woman. She's had a stage 3C grade 1 endometrial carcinoma, historic 2015. She's had standard treatment for that, and then had post-operative adjuvant radiotherapy and brachytherapy. In November 2016, she's developed an aortic cable lymph node, which was again successfully resected and she's continued on surveillance. Next slide, please. She's then had 2018 ER positive, HER2 negative breast cancer, which was excised and then had post-op radiotherapy. Next slide, please. So she's come up quite a few years after her scan with, and she's not so well. And I think we just wanted Mandy to make a comment here, because some of these cases clearly are going to have been operated on prior to our reflex testing, but they can still potentially get recurrent disease, which may be Lynch syndrome and mismatch repair deficient related. Mandy, do you want to just make a comment there?
Yeah, no, this case came through from one of the CNSs who got in touch with me, because obviously she'd been to a Lynch syndrome webinar and actually went back and saw this patient in her CNS clinic and was like, oh, actually, does this relate? And she got in touch with me, and I obviously passed it on to the experts, you, Jim, and Fiona, and asked questions. And I think I just wanted to highlight that actually, you know, there are people like this, and it doesn't matter what profession you are, whether you're a CNS consultant, you know, these patients can come through on lots of different pathways, and don't be afraid to ask the questions or get in touch and go, actually, I don't know if I'm on the right lines or not, but will this have an impact, or what do you think about this? Because I think this bit coming to a webinar and then getting in touch has actually helped this patient and helped this CNS quite a lot. And I just wanted to highlight the importance that it doesn't matter what or who you are, get in touch with these questions, because it can have a great impact on that patient pathway, and the knowledge of that professional as well.
Absolutely, and the MDT, which is going to be set up, will have Emma or one of her colleagues will be joining us. I think we've persuaded Mike. I'm trying to persuade Dina to join that MDT, and it's going to be really interesting because these are new treatment pathways for the patients, and we can affect very significant changes. So there were two things I briefly wanted to raise about this case. So we've got the histology, which I'm going to ask Lucy to perhaps make a comment on. But if we've got a metastasis, Mike, and we can't get tissue, and we can get some information that meets the criterion that you mentioned before about MSI high, perhaps immunohistochemistry, would we be able to treat a presumed mismatch repair metastasis on the basis of the information about the primary, or would we need histology from the metastatic deposit?
Generally, you can go with what the primary would have shown, because it'd be very unlikely that it would change from a deficient to a proficient metastasis. So yeah, it's worth saying. Katie and I have had some people recently where they've got tumours and it's sort of MSH2 pole E, and then the tumour itself was MMR proficient on the analysis. So there are some intricacies to it, but if you've had an MMR deficient tumour, you wouldn't need to rebiopsy a metastasis. That's actually very helpful, but I think again reinforces the importance of patients developing metastatic disease to potentially do an MMR immunohistochemistry on the original tumour, because there will be 1 in 6 to 1 in 10 of these cancers which will be of an undiagnosed mismatch repair deficient cancer. And just, Lucy, I was just going to ask you to make a comment that in addition to some of these difficulties with the clinical management, we're going to get some difficulties in histological interpretation. There may be clonal loss of the mismatch repair protein. This was actually the report that was I've taken verbatim from the histology report that was done. So there's isolated, and this, Renius, I promise, is the last slide. It's isolated loss of PMS2 with normal MLH1 promoter methylation. This has been associated with PMS2 and MLH1 germline mutated in patients with colorectal cancer.
and they have referenced one of Miss Newton's studies here. So how should we, you know, Mike's talking about being able to use MSI and IHC. Should we be using MMR if we've got these uncertain cases? How do we go about getting sufficient confidence where we can decide whether or not to use immunotherapy treatments, do you think? And I apologise for not giving you advance warning about this, and you may say I'm not prepared to comment.
Hi, Jim.
Rainis?
It's okay, but I've only just come back into my office because I had to go and do a frozen section.
Okay. So I guess it's what do we do about these difficult? I mean, obviously it's very straight. You know, it's nice and easy if you've got complete loss of the protein across the tumor. What do we do about some of these difficulties? You know, Mike's talked about, you know, fairly straightforward criteria for using immunotherapy. How would you interpret this, or would you say I can't really? And this was just taken verbatim from the pathology report.
Mm-hmm. So yeah, it's not unusual to get one that doesn't quite fit in with what you're expecting. When the results are a little bit strange, what we would normally do is repeat the stain that we're not sure about, or sometimes even repeat it on a different specimen, or a different section, if it looks a bit odd. If we're getting the same unusual pattern of staining, over here, I'd probably discuss it with my other colleague who's got a bit more experience. I might send an email out to Fiona or to Mike, and sometimes just doing a literature search for that specific slightly odd staining pattern will bring up lots of case reports and things like that. So there are ways around it, usually involving discussion with colleagues.
And what about colleagues in other hospitals that are having difficulties with interpretation?
Yeah, so since we've just quite recently started training people, and people in other hospitals have started working up their own cases, Ray and I have just said, just approach us with anything that you're finding difficult. We're happy to give advice about anything that you've not come across before. Ray's been training GI pathologists across the region, and we'll have told them about the main kind of potential pitfalls that they might come across. And then again, if we couldn't resolve the problem, we'd probably just advise including other people from the wider team, because they may have more experience of it. Sometimes if I'm absolutely not sure and it's very strange and I don't know whether to call it MMR deficient or not, I sometimes do an MSI to see if that clarifies it.
Yeah, that's very sensible. That's very helpful. I'm sorry to ask you and so just final words. Emma, you know, obviously we've presented some good responses with colorectal cancer. Emma, has that been your experience? Have you had much cause to use immunotherapy in your patients?
So yeah, I mean, it certainly is being used now because we've got recent endometrial cancer specific guidance for immunotherapy as well. And it has relied heavily on getting the archival tumour blocks because, of course, it's only been recently that we've been testing our endometrial cancers using reflex MMR immunohistochemistry. So we've required, you know, getting hold of the archival tumour blocks and doing retrospective MMR testing, if you like. But yes, anecdotally, we're getting some really good responses from treating our recurrent endometrial cancers that are MMR deficient with immunotherapy.
That's fabulous. Marie, sorry that we've gone on a little bit long, but I felt that was so useful. I absolutely the cases, and I just want to finish by thanking everyone who's participated with the MDT. That's been much appreciated. Thank you.
Yeah, no, absolutely, Jim. I couldn't agree more. Fiona, you did have your hand up. Did you want to come in with something there?
No, it's
You're
fine.
okay. All right. It just remains for me to say thank you to everybody who came today, who was in the audience. And I think what we've just witnessed here in this MDT discussion is the appetite and the complexity of just how important Lynch syndrome is. And I think the take-home message is that whether you are an expert already or whether you're starting your genomic journey of highlighting Lynch syndrome and indeed embarking on mainstreaming Lynch syndrome, we're a large team and we're here for you to reach out. Mandy is absolutely storming the whole of the region about making contact and doing education. So you're not on your own. Our feedback is critical. And I know for a fact that this MDT discussion is something that I would like to see happen again. However, it's really important that we hear from you, the audience, of whether or not this is something you want. So please, can you take a moment to just scan this QR code? Even the speakers, please, would be brilliant. And just give us a little bit of feedback about this session. And Jim, I think it just remains to be said about how the energy of that MDT discussion is kind of paving the way for the regional expert network and the MDT. Do you want to finish off with a comment about that?
Yes, I mean, Fiona, if she's still there, may be able to update us. We're about to advertise for the coordinator. Once the coordinator's in place, we will be able to get it up and running. We need to make sure that Mike and Dina and hopefully Lucy or one of her colleagues can spare an hour a fortnight to do that. But it's clearly some really interesting and wonderfully effective treatments for the patients, which have not been available until very, very recently. So it is exciting stuff. I truly believe that.
It really is. And this is what this is all about, is that it's all about improving patient outcomes. And so thank you, everyone. Sorry that we overran a bit, but I think Jim was right. It was really important that we maintained that richness of that discussion. Mandy, thank you very much. Thank you, Mike. Thank you, Fiona. Thank you, Emma. Thank you, Lucy. Thank you, Kate. Thank you, Jim. And in the background, I would like to thank Rainis, Salim, and Anthony. We couldn't do it without you in the background and the project management office. So thank you. Bye-bye now.